Hello, welcome to this week's concept map presentation, the approach to a patient with vertigo. Please bear in mind that these presentations will not cover the pathology and management of each condition, but rather the identification of it. Dizziness is a common complaint in patients, and evaluating a dizzy patient is challenging. Two studies performed approximately 30 years apart have confirmed that there are 4 general subtypes of dizziness: vertigo, near syncope, disequilibrium, and psychophysiologic dizziness. An approach to a patient with syncope and disequilibrium has already been released last week, so today we will focus on vertigo. Vertigo is defined as an illusion of motion, and patients would usually feel as though the room is spinning or like they're descending in an elevator. If someone presents with vertigo, it is very important to distinguish central or peripheral. Central vertigo indicates the involvement of the cerebellum or vestibular nuclei within the pons and medulla. Peripheral vertigo indicates involvement of either the 8th cranial nerve or the vestibular apparatus of the inner ear. Their presentations are slightly different. If the patient presents with any of the CNS symptoms, such as dysarrhythmia, diplopia, abnormal gait, weakness, incoordination, or CNS signs like cranial nerve abnormalities, ataxia, positive Romberg, or abnormal nystagmus, we consider central vertigo. Central vertigo, but transient, might be transient ischemic attack. A constant but acute onset, consider posterior stroke, cerebellar bleed, or vestibular migraine. If it is progressive and chronic, think of a brain tumor or multiple sclerosis. If the patient has no CNS signs or symptoms, and the symptoms are more likely to be peripheral vertigo, we look at the duration of the attack and other associated symptoms. Recurrent episodes and last only seconds to less than a minute. It is more likely to be BPPV, which is the most common cause of vertigo, results from the inappropriate presence of calcium particles in the semicircular canals. If the patient has no hearing loss, it might be vestibular neuronitis. It is usually a single attack lasting days. If the patient has loss of hearing, then consider Meniere disease, infarction of the labyrinthine, acoustic neuroma, or labyrinthitis. Meniere also have recurrent attacks lasting minutes to hours associated with tinnitus and ear infection or upper respiratory tract infection. This slide summarizes how to differentiate the different causes of peripheral vertigo. I hope that it helps you. Vertigo is one subtype of dizziness, and we will present approach to a patient with dizziness in the next presentation. Again, we do not recommend you to memorize these concept maps, and instead, we hope that through these concept maps, you will learn the process of diagnostics reasoning, the ability to critically examine a list of differentials and rank them according to likelihood, and pick up what does not fit. Using these examples, read some symptoms to diagnosis books and create your own concept map for each symptom. Thank you very much for listening.